Everybody had some really great questions, so I wanted to make sure I answered them all. All right, so enteral feeding practice, how'd we feel? We were frustrated, we were excited, we were like, what the heck, do you actually do this every day? Yeah. Who loved going through all those formulas and figuring out what to use?
Yeah.
Not so much. Okay. I promise you start to get quite fast at it because you start figuring out like certain patients can tolerate or really need certain formulas, and then you really only like need to know a couple formulas. It's only until you get into pediatrics and you've got like little babies that you're like, wait, what? There's how many formulas for what all these little babies? But for adults, it's not too bad. Okay, so let's walk us through this. So for our first patient, we have AJ, who is a 72-year-old female, status post a cerebral vascular accident, so some sort of a stroke maybe. She has no gag reflex or cough and no other significant previous medical history. So before we even move on, I always, as I'm reading my patient backgrounds, start to like think of anything that kind of like throws up a little like, hey, this might mean something in terms of my, nutrition, assessment, and intervention. So anything from this statement that you guys would pull out that would say, I might need to keep this in the back of my mind. What do you think? Yeah.
No gag reflex.
No gag
Cough.
reflex or cough. Why would that throw up a little like red flag there?
Aspiration.
Aspiration risk, right? So already before we've even talked about nutrition support, we've even talked about nutrient needs or what's going on, we just know that this patient probably is at high risk for aspiration. So definitely keep that in the back of your mind. All right, anything else?
CVA.
CVA, right? So she's had a cerebral vascular accident. We don't know to what extent. Usually that refers to a stroke. This might be a patient who is now paralyzed and can't eat or drink. So this may mean a long-term issue. This could be a short-term issue. Is this somebody who now can't speak? So just, again, something to think in the back of your mind before we've even met this patient, that there's a couple like red flags that might affect her nutrition. Okay, so I gave you all the nutrient needs for this patient. So we've got 16 to 1700 for calories, 55 to 65 for protein. All right, and then fluid needs 1600, right? I got a couple questions about what's the best way to calculate fluid needs. Honestly, it really doesn't matter. For adults, I like doing the quick and easy 1 ml per kcal. That doesn't necessarily mean that that is the gold standard. It's just the easiest way to do it. If you like to do it by body weight, that's fine. Only thing when we think about calories, protein, as well as fluids, is remember we really need to take a look at what is the body weight of that patient. Are they actually that weight? Is that a dry weight? Are they fluid overload? Are they super dehydrated? Were they weighed with in a bed scale versus a standing scale? Were they weighed with like a halo on their head that would affect their weights? So just something to keep in mind. And this comes up quite often. I actually had a conversation with our clinical documentation team last week because I had a patient that was like very chronically underweight, and then his length scores were like all over the place. And so it looked like he had at one visit, he had like a BMI Z-score of like -4, which is like severely malnourished, but he has developmental disabilities where he's also contracted, so like it's hard to get a weight. But then like a week later, he had like a height length score that was super high, so then he had a regular BMI Z-score. So like the team was like, how do we assess this, because his weights are also all over the place but low. So it is really important to take a look at your patients to be able to actually make sure we have their needs calculated out right. All right, so moving on. Question A for this patient. What type of formula would you recommend and find an appropriate formula that meets these specifications? So let's think about types of formulas. What did you all come up with? It's some great conversations. What types of formulas? Let's think about characteristics of formulas for this patient. All right, what are we talking about? Who wants to give me examples of the formulas that they chose? What was that? Whole protein? Yep. Whole intact protein formulas, because there's no indication that there's any malabsorption or GI issues, right? Perfect, right? So what other proteins or other, whatchamacallit, anything else that you might think about for formula types for this patient? Anybody worried about increased needs, or were her needs pretty standard? Yeah, pretty standard, right? Just because you have a stroke, I know you're going to talk a lot about this with Mikkel, but no need for increased needs at this point. We haven't noted that she had any other surgeries or that she has a fever or anything like that that would increase her needs. All right, what is everyone's thoughts on fiber? Do you think she needed fiber? Don't need fiber? Who knows? If you really wanted to go with a standard intact protein formula with fiber, sure, we could just monitor and make sure she tolerates it. If you didn't want to, totally fine too. Fiber's a little bit arbitrary in the sense that you just kind of take a look at your patient and see, would fiber be beneficial? Would it not be beneficial? Do you want them to be able to tolerate their feeds first and then introduce fiber? So it's really kind of open. Yeah.
You said she's paralyzed and not able to move.
We possibly, because she had a CVA. So with strokes, we know that she could not be.
So in that case, fiber might help with her bowel movements if
It
she's
could.
not getting
Yeah.
physical movement.
Yeah, definitely. So if you went in and met with this patient to find that actually, like, physically she was compromised, then maybe you're like, you know what, let's throw the fiber in. We'll do the formula with fiber. Okay. So what were some of the examples of formulas that you all came up with? Nutrin 1.0, right? With or without fiber? Sounds pretty good. I like it. So probably going with a general Nutrin. Anybody come up with anything different? Yeah. Replete. So how come you went with replete?
You have one decal for meals. I thought that was pretty standard.
Mm-hmm.
Because she doesn't have any decals, and also the ones of protein fit into the range that she.
Mm-hmm. Yeah, you could probably go with replete. Not everybody has replete with fiber is one thing. UCSF is nice. They have a lot more formulas than most. The other thing with replete is, what was I going to check out? It looks like mineral wise, it's okay. Yeah, replete probably was okay. Probably more often than not, someone would go with Nutrin just because it's just the go-to easy, most people carry it. If you were worried about the fiber, you could definitely go with replete because that's their like more focus is because it's a fiber enriched formula. So if you were not really worried about fiber and you just wanted to go with the standard formula first, Nutrin is more of the way most people go. Okay, all right, so next question was, where should the tip of the feeding tube be placed?
The stomach or the intestine?
In the intestine. So yes, why the intestine? Yes.
Like you said, that's a bariatric time affects shit and gag reflex and this is one of them.
Yep. Perfect. Yeah. So that little red flag, little piece of information we talked about of her being at high aspiration risk would indicate that we probably want to feed post-pylorically, right? So having a high aspiration risk means we want to feed lower into the GI tract, so into the intestine. So you could do into the duodenum or into the jejunum. Who thought, I know this wasn't part of the question, but when I had this discussion with some students, who thought NJND or who thought the actual surgical hedge procedure for tube? Anybody think about that? A little bit. So do you think this patient, we would just do a nasal tube insertion first? Or should we just go straight to the hedge tube? Yeah. Great. Yeah, so this is one of those patients that, again, we know that she had a stroke. Maybe this is a long-term issue where she's not going to be able to cough, have a gag reflex, swallow, feed herself. So the PEDS tube would be more appropriate, so of a long-term feeding option. But for, right off the bat, probably placing the nasal tube is probably fine. Yep. This actually happened to one of my first nutrition support patients. They thought that he'd be able to be nasally fed, and he ended up staying in the hospital for a month. And I got to follow him when I went to different services and see that his swallow never returned. They did the video swallow to see that he was silently aspirating. So So then they did the G-tube placement after he had a stroke. All right, so calculating the total volume of this formula that the patient, that would meet the patient's energy and protein needs. So let's say we use Nutrin 1.0, which is probably similar to the Replete. Take me through how I would figure out how many mils I would need. Who wants to walk me through it? Mm-hmm.
Like you divide what times I said 1,650 kilocalories per day.
Okay.
Divided for 1 kilocalorie per milliliter, so it's like the same amount in milliliter.
Oh, perfect, right? So it's 1 calorie per mil, right? So if we're gonna meet energy needs, so you used 1650, right? So if we did 1650 mils divided by 1 kcal per mil equals 1,650 calories. Right? Makes sense? All right, so how do we figure out how much protein is in that?
I divided like 60 grams per day for 0.05 grams per milliliter. Because the formula provided
There we go. What's the formula provide?
40 grams of protein for 1,000 milliliters, so it's like 0.05 grams per milliliter.
All right, so this is from the formula sheet, right? From the UCSF formula sheet. Tells us that for every 1 liter or 1,000 milliliters, there's 40 grams protein. So we would need to find out how much is in 1650 if we look at that, right? So how would I do that?
And
How is that?
actually it's like 0.05 grams per milliliter. And
Is that 40 divided by 1,000?
yeah. 0.04.
Mhm. Right, so it's 40 grams per 1 mil. If you were gonna do a percentage, right? Does that make sense? How did you get the 0.055?
And like 40 divided for 100 milliliters, it's like 0.04 grams per milliliter.
Right. Sorry, did you say 0.55 before?
Oh, okay, maybe.
Okay, that's okay. I was like, I was trying to figure out what you
no,
guys said.
0.04, yeah.
Okay. The other thing that you could just do, you could do 0.04, or you could just do 40 over this times 1650 mils, right? Because that's what you need. You know what you need, right? So if you're trying to meet your calories, you know you need 1650, right? So you just do 40 grams per mil times 16 mils. That's going to cross out your units. And then how much is that? 66. So that's going to give you 66 grams of protein, right? 40 times 1650 divided by 1,000. All right, so if we are getting 1650 mils of this formula, we're going to get 1650 calories and 66 grams of protein. Does that meet within our estimated needs? So yeah, so this is a tiny bit over what I said the suggested needs are. So usually we try to aim for like 5 to 10% of meeting patient needs. You know, sometimes we are like spot on and can meet them both great in that range. Sometimes one's a little bit high, one's a little bit low. We try to get within the 5 to 10%. Okay. Any questions on how I got calories and grams of protein? Okay. D then asks, assuming the patient is going to be fed continuously over 24 hours, what should be the goal hourly rate? So how did I figure out rate? Yeah.
Total amount required, volume required divided by the time.
Yep, exactly, right? So if we know that we're giving 1650 mils, right? We want to run this over 24 hours. So So we just divide by 24 hours. That gives us what? 68, about 68 an hour? 69 an hour, okay? Right, so about 69 mLs per hour. So that's our rate. So if we run 69 mLs an hour times 24 hours, we should get about 1650. Okay? All right. Next is our fluid. All right, part D is asked, does this volume of formula meet the patient's estimated fluid needs? If not, what needs to be added? So how do we find out if this has met fluid needs?
Like the water percentage of the
Right.
formula?
Great, so what is the water percentage that we're gonna get from the UCSF formulary sheet?
85%.
Perfect, okay, so 85%. So that means that 85% of anything you provide for your total volume is gonna be water. So how do I find that out from how much we're providing?
You find 85% of 1650.
Yep, so 85% of 1650. You can do 0.85 or 85 divided by 100, right, times 1650 mLs. And how much does that provide?
1402.5.
1402 mils, okay? So from our formula, if we give 1650 mLs, we're only getting 1402 mLs of fluid. So does that meet our patient's needs? No, right? So what would we need to provide? So it does not meet needs. So how much do we need to provide, and how do I figure that out?
At least 200.
Katie, what do you got? Great. Perfect, right? All right, so you would need to take the total that you need, 1600. Right, so this person only needs 1600 mils per day, right? So subtract 1402. And how much do you get? 240, right? Is that what you said?
Why is it 600 not 1650 if you're doing 1650?
Because the calculated fluid needs are 1600. Good question. Yes.
Then it will give you like 200.
Oh, hold on, that was a lot of numbers at once. Was it 200 and 198? Okay, so we still need to provide 198. How do we give 198? What would we do?
Divide that by 24 hours.
We could divide it by 24 hours, or how else could we provide it? We could do it as a water flush. More often than not, we would do it as a water flush. Would we ask this patient to consume it by mouth?
We could.
Right. If we had a patient that was still able to drink, you could ask them to consume it by mouth. For this patient, because of the high aspiration risk, we would not ask them to consume it by mouth. Right? So we would provide this as a water flush. How would we do the flush? You want to do it twice a day, 3 times a day? What do you guys feel like? It's like 200 mils, right? Let's do 2 times a day water flush of 100 mils. Right? So provide 100 mil water flush 2 times a day. Okay. And that's how you can do that. If you want to do it 3 times a day, you could divide it by 3, 4 times a day, you could divide by 4. Yes.
They're getting 69 bucks an hour, and then you flush another 100. What if that, like, not overload, but like make them feel like really full?
So think about it this way. How much is 60 ounces?
Oh, not that much.
60 mils is how many ounces? It's 2 ounces. So they're getting about 2 and some change ounces per hour. So if you think about you drinking 2 ounces an hour, it's not that much. If they only got 100 mils then twice a day, that means that of those hours, that's another, they might be getting anywhere between 3 to 4 ounces 2 times per day. So another way that you can think about water flushes is if somebody is getting IV fluids, they may not necessarily need the water flush because they're probably meeting their extra fluid needs through the IV fluids if they're getting to. So there's other ways of doing this, but more often than not, if you have a standard tube feeder, they're not necessarily getting IV fluids, so you would provide the water flush or ask to provide a water flush. All right, any other questions before we move on to our second patient? Okay, all right. So let's move on to PK. So PK is an 80-year-old male patient with diabetes mellitus, and he already has a PEG tube. All right, so we got a G tube in place. His blood sugars are running from 120 to 140 today. That's high for anybody. I know we talk about diabetes next semester. He's 5'11" and weighs 180 pounds. So if we were using part A, if we're using 30 to 32 calories per kilo and 1 to 1.2 grams per kilo for protein, what are his energy, protein, and fluid needs?
2454 to 2617 kcals.
All right, so everyone got about 2450 to 2620-ish. Okay, perfect. What about grams of protein?
82 to 98.
82 to 98. Okay, what do we get for mils per day?
Similar to the kcals.
All right, anybody calculate based on body weight? Everyone do mil? Yeah, just to get a, what was your range for the based on body weight for mils?
About 2,700 mils.
About 2,700 mils. Yeah, so a little bit, probably a little bit higher than the calorie needs, but good, perfect. Okay. All right, so question B asks, so let me write up these energy needs up here. So we have like, okay. All right. So part B asks, what formula would be appropriate for this patient and why, and how many mLs does he need every day to meet 90 to 110% of his energy and protein needs? So let's talk about formulas. What did you all come up with for formulas? What was that? Boost glucose control. All right. Anybody else come up with a different formula to use? Glytrol. Okay. Anybody come up with any different ones to use? So everybody either use boost glucose control or Glytrol. What did you come up with?
I did replete fiber.
You did replete fiber. Okay. Similar to, let me pull up to Glytrol. Okay. Anybody use anything else different? Yes. Use Peptamen. Okay. All right. So anybody else use anything different? Yes.
The
Novasource Nestle. Renal formula. Okay. All right. Yes.
I have a question about, so the very first one, the glucose control,
Mhm.
if you're calculating that out, I guess if you're calculating out the protein needs are way too high,
Mm-hmm.
so then if you have someone with diabetes, like how do you weigh, like, you
Mm-hmm.
want to control blood glucose levels, but then you don't want to overload the protein on the
Right.
side.
Right. That is a great question. Okay. We are going to talk about that. So we'll start there. So first of all, the boost glucose control and the Glytrol are very similar. They are our carbohydrate controlled formulas geared towards patients with diabetes and or blood glucose control issues. So first of all, boost glucose control, why did you choose that one versus the Glytrol? For those who chose boost glucose control.
The caloric density.
The caloric density, okay. Any other reasons? No? Okay, all right. So for a patient such as this, and it's not necessarily that it's wrong, but because they have a G-tube in place, it probably means that they're not eating a lot. We don't know for sure because we don't have that information. But typically for these patients, we would use the Glytrol just because it's a standard tube feeding formula, whereas the Boost Glucose Control is one of our oral supplements. So we can use oral supplements as tube feeds, but we usually don't unless that patient is actually starting to eat or drink. So for this patient, we don't know because there's no mention of it. It was just a one-liner. So loose glucose control could be a potential option for this patient. But more often than not, if they have a long-term like tube feeding option, probably the traditional tube feed formula is where most people go. Yes.
Was that indicated on the reference sheet, or did you know that, or?
It's just that, no, I was just giving you, that's why it's not necessarily wrong, but he has a PEG tube, so knowing that he has a G tube, he's probably primarily tube fed, because you wouldn't necessarily have a long-term tube placement. So that's why, like, most thought processes, okay, if this is a long-term tube placement, probably need a traditional tube feeding, they're not probably taking that many things by mouth. But we don't know this from my one-liner that I gave you all, so he may actually be drinking a little bit more, and the tube feed was for overnight, so we don't know. So that's why I'm saying that it's not necessarily wrong, just most patients that have long-term like tube feeding placement normally are just tube fed and they're not really eating. So that's why it's not wrong, but more often than not, people will just go to the Glytrol. Okay, so for those that picked Replete, why was Replete chosen for this patient?
I think I chose it because it was high in protein.
High in protein to meet the protein needs? Okay. And what about for the Novosource?
I think I miscalculated the calorie count.
Okay.
I was looking for like a really high calorie one because it is high. in
Okay.
protein.
Gotcha. Okay. The thing I would say about Novosource and the renal formulas is typically those are saved just for the kidney patients because the mineral contents are extremely low, and normally they are concentrated. So, but for Replete, Replete may be an okay option. More often than not, for something like this type of patient, if you were worried about protein, you can always add in Beneprotein modulars. So instead of switching to the Replete fiber formula. Okay, so why don't we go forward and use, how many people used Glytrol? And how many people use the Boost Glucose Control? Okay, that's not very many hands difference. Okay, let's go ahead. Do we have a preference if we use Glytrol or if we use Boost Carbohydrate Control? All right, I'm gonna use Glytrol then, just because I have this one up and for a little bit of sake of time, because we're getting pretty slow. Okay, all right, so for Glytrol. So the question asks what formula would be appropriate for this patient and how many mils does he need each day? All right, so with this problem, you had to do quite a bit of guess and checking because the protein and calorie needs were very off. I got a lot of questions in the discussion about how do you prioritize meeting protein versus calorie needs, and do you choose one versus the other? And honestly, baseline, usually you meet calorie needs first, but if you do have patients that do have unique, really high protein needs or really low protein needs, then you could focus on the protein. The thing with meeting calorie needs first is that if you end up being lower on the protein, you can always add in something like Beneprotein as a modular to then meet those protein needs. All right, so for this patient, I chose 2,400 mLs of Glytrol as my first go-to. So if I had 24 mils of Glytrol, how many calories would this provide?
2,400.
2,400, right? So Glytrol is 1 kcal per mil. And that came from the UCSF formulary. Right, so that's 2,400 kcals. All right, how about protein? There's should be
108.
45 grams per 1,000 mils, right? So there's 45 grams of protein for 1,000 mils. We are giving 2,400 mils. Again, this is from the UCSF formulary. That's going to give you
108.
108 grams of protein. All right. So it's 2,400 calories within 90 to 110% of his needs. Yes, question.
I think it's 2,400
I just picked it.
Oh.
Yeah, this was just, I randomly picked that number. So this is how I go back and guess and check. 2,400 calories, is that within 90 to 110% of his needs? Right, so his needs, how would I check that?
Find 90%
Yes,
of
yes, so you can find what 90% of these numbers are, or you could just take 2,400 divided by 2,450 times 100, make 108 divided by 8298 times 100. Okay, so these both fit, because I double checked before coming to class today, that these fit within there. Okay, alright. D then, or C asks you decide to bolus feed this patient, please write a feeding schedule. Alright, so we had lots of questions about bolus feeding. So, bolus feeding. If you looked at the reference sheet that I posted online, it gives a very good general starting point for starting boluses. So remember, boluses are the little bit larger volumes all at one time, and then like, you know, to kind of mimic meals, so breakfast, lunch, dinner, or breakfast, snack, lunch, dinner. So you typically don't go over 500 mils at one bolus, because if you think about that, 480 mils is 16 ounces. So that would be quite a lot of volume at one time. So if we were to bolus this patient for goal, what could we bolus them at? Let's say we're using the 2,400 mils. What would be some ideas? Not just to start, but as a goal. What do we want to work up to? If you had to give 2,400 mils of formula over a 24-hour period, how would you want it bolused?
10 cans per day.
So 10 cans per day is
2,400.
2,400, okay. So, but would you bolus 10 cans, 3 cans at one setting? What do you got, Sophia?
I was thinking like 2 to 3 cans.
Okay.
As a breakfast, lunch, dinner.
Okay.
And the rest that you need to go up to 10 for these snacks.
Okay.
Like between breakfast and lunch and dinner.
Okay, so let's say we were gonna do that. We did a breakfast, a lunch, a dinner. We can do a snack, maybe. Okay, so how many cans? 2 to 3, you said? Okay.
Yeah.
Each can has anywhere from 237 to 250. So let's say, what was that?
Because the maximum is what in a day?
Is
Or no, at a one time.
we try not to go over 500.
So I would do 2 cans.
So 480 at one time. So 480, 480, 480. Okay. How much is that? That's 12, 13. I don't have that off my head. Just got the calculator.
It's 1440.
1440. Okay. So then how much left over do we have? We need 2,400 minus 14. We need 960 left, right? Divide by 3.
320.
320. So you could do 320, 320, 320. So that could be a bolus regimen. This is a total creativity, right? So that's 6 feedings. That's fine. That's good. Yeah.
What if, for example, the patient doesn't like eating in the morning or doesn't like afternoon in the morning?
Perfect. Right. So what we can do is we can take these off of meal times and then say, all right, so we're gonna do this at 12, 3, 6, you know, and then just adjust the times as so.
No, but like in general, for example, you would still do the time wise. Could you make, for example, 200 in the morning? And
Oh, yeah. Oh, yeah, yeah, yeah.
Within
You can change the volume around as much as you want.
But is the cap of like going over 500 a hard cap?
It's not a hard cap. It's just most patients don't tolerate over that. Yes, James.
In the reference, you said they kind of need to start at a smaller volume and slowly work it up. Is that like a hard rule, or I mean, if we do something like this, we did, where you start with the larger goal?
Yeah. So the question is just asking you what your regimen would be, not initiation and progression of what what you would like it to happen. So this would be just at the end of the day, if this patient was meeting their goals, what would you want it to be? So in terms of when you have patients that are starting brand new, you would not have them start on this. You would have them start at the 120 mLs every 4 hours, and then 24 hours work your way up. So those first couple of days, they are not going to be meeting all of their nutrition needs. It's a great question.
That's just the beginning.
Sophia.
How do you know what the hour period that they have to be fed?
Great. That's a
Whether it's 1 hour, 4 hours.
Yeah, that's a great question. So think about just general digestion and absorption. How long does it take? Yeah, right. So 1 to 2 hours for like a good, everything is working just great. Probably going to give it a little bit more leeway time for somebody who's sick or on medications if they're slowing things down. So that's why the rule of thumb is about at least every 4 hours that you would feed, or when you would give the next feed. But that doesn't necessarily mean that somebody else like can't take that. So like babies, for instance, you wouldn't like make a baby who's an infant wait 4 hours their feeding schedule because their stomachs are smaller and stuff are going to be every couple of hours, especially when they're younger. Yes, Ron.
In terms of the feeding schedule for the bolus feeding, you do it while the patient's awake, right? Or
Oh yeah, you can do it when they're asleep too, but you mainly do it when they're awake. And some patients want to do it themselves, so they just kind of like open up their little Mickey's and drop it in. Okay, so this part is kind of your creativity, also working with maybe if they have medications that they're getting. So again, you're not asking your nurses to like run back to the bedside like several times a day. It's going to be too much. Okay, and also thinking about when you are transitioning this patient to home and they're going to do bolus feeds, is this going to work with their schedule at home? Or like, you know, Mike brought up, like maybe they don't really have the time or they can't eat in the morning that much, so then would you adjust it for when they're at home? All right, Dee asked about the fluid. How much water does this provide? So how much free water is in Glytrol?
84%.
84%, right? So this is from the UCSF formulary again. All right, so what is 84% of 2,400 mils?
2 liters.
So the 2,000 straight?
Yeah.
Okay, so this patient needs how much more?
About 400 to 500 more.
Yeah, so we'll just say 500 more to make it easy. All right. So let's take. So remember, this is from what you calculated. All right, and how are we going to provide this extra 500? Water flush, yeah. This patient, we don't know again if they can drink, but we could do it as a water flush. You know what we could do? We could, or actually, let's make it super easy to go with this. Let's say that this person had a fluid need of 2,600, so they need 600 more mils per day. You could do a water flush of 100 mils after every bolus if you wanted to.
Would you do it after or before the bolus?
Usually you do after because it also helps with cleaning the tube out. They will do a quick saline rinse before they give the feed, but then the water flush helps just really push everything else through. All right, so the last question asks how you would write your tube feed recommendation. Do you guys mind if I erase this so I can write it up right here? Okay. Okay, so this is how you would write this in a dime note in the I section. Okay. So this is the I section. And this is our food and nutrient delivery. Okay, so this is what we're going to recommend. So we first have to say that we want to recommend veg. I guess this needs to change right up to the beginning, sorry. So we want to recommend to initiate enteral feeding regimen. You break it up like so. Formula. For this case, we used glycerol. Route, or root, we're gonna use his PEG tube. And our regimen. So for this patient, since it looks like he maybe already gets tube feeds because he has a PEG tube, we can just provide what the regimen is, or so that we can learn how to do this, we're gonna talk about initiating and progressing our tube feeds. So we're gonna initiate bolus feeds of 120 ml every 4 hours times 24 hours. If tolerated, then advance by 60 mLs. This tolerate that advance by 60 mLs per day until full regimen is reached. All right, so here's how you do your whole slew here. So we're gonna recommend to initiate enteral feeding regimen. We have to identify what the formula is. So our formula we picked was glycerol. We have to identify what the route is. So we're gonna use his PEG tube, okay? And then we have to identify what the regimen is. So since this patient, we don't know if they're starting tube feeds, so we're doing this as practice, is that we're gonna initiate bolus feeds of 120 mLs every 4 hours for 24 hours. So that's what's recommended on the reference sheet. If this is tolerated, then we'll advance by 60 mLs per day until goal regimen is reached. So that means that every day then we'll add on 60 mLs to his bolus until his goal regimen down here is reached. So day 2 would be 180 mLs every 4 hours. And then the next day would be 240 mLs. Okay, and so then they would keep advancing until we get to this regimen right here that you identified out. Yes,
How did you pick 60?
that's just the general guidelines that I provided in your reference sheet. Yes, Katie.
So you
do it every day, isn't it? It's not every feeding time.
So every day you're increasing your boluses by 60 mLs. Yeah.
Why not, like, why does it have to be a whole day? Why can't it be like, if they handle this one, then pick it up for like 8 a.m.?
General rule of thumb, if you have patients that tolerate really well, you can say increase by every 12 hours. If this is somebody who was a regular tube feeder before this, you may start off at this, what your goal regimen is, because they were already doing it. This is just for straight off the bat, if we had anybody that you didn't know anything about. It's a good question. Yes, James.
Until you met your goal regimen, they couldn't even have what you do.
You would continue to monitoring them. They're usually fine if they're getting a little bit of something, especially if they came in previously nourished. But I mean, if it ends up being weeks and weeks and they still can't, I shouldn't even say weeks and weeks. If it's been over a week, because you try to aim to get them up to goal within a week, and they really can't tolerate what you're giving them, then you would switch it up. Either pick a more concentrated formula to provide less volume if they can't tolerate the volume, or maybe the bolus is not the way to go. You're gonna have to do continuous at first, and so you can switch up how you're providing your enteral nutrition. Yes.
So the benefits of bolus versus continuous, we just that bolus is like you have more time to digest and kind of recover then again.
Yes, and also you don't have to be hooked up all the time.
Oh,
To the
that's
bowl.
benefit.
Yeah, that's the big benefit. So other things you need to include is you need to include what your actual regimen provides, because you need to show that you're meeting your patient's needs. And then if you do add any sort of water flush or anything extra, if you're adding a packet of better protein or what have you, you need to include that as well. Okay, so that's just in the eye portion. We'll talk about signs and symptoms as when we talk about putting it all into a note at a different time. But this is what would be how you write out the regimen. Okay, I am going to have to literally fly through the beginning of parental nutrition, and we will probably finish it up on Wednesday, and then I will be behind for pregnancy and lactation, but that's cool. Okay, but let's get started, because I have to return all my materials. So any questions as I'm getting started up for this? For enteral nutrition. Still letting it all sit in a little bit. Okay, that's okay. It's kind of a lot. Where's my thing? So for this semester, again, all we're going to be doing for calculations is this. So practice what I posted, this assignment, and this is what I will see if I have another assignment that I can post for practice, but this will be the type of questions that you get on the exam, like a small blurb about a patient and calculating regimen. Being able to identify certain formulas that would meet protein and energy needs. Being able to know like when you would have a patient get a nasal tube versus a G tube. Okay, all right, let me pull up this and we will at least start for today. And I will leave this stuff on. Okay. All right, so we're gonna be switching to talk about the basic concepts and the ins and outs about IV nutrition or parental nutrition support. All right, so very similar to last time, I'm gonna give you like the basic overview about what parental nutrition is, where the access is, what actually makes up parental nutrition. I brought some fun show and tell for getting a look at what central lines look like. The nurse educator that I work with for oncology let me borrow Chester here. So I have to return him today because the families need him so that they can learn about central lines too. How we administer parental nutrition and complications, and then again, how it fits into the NCP process. All right, so as you remember from last time, parental nutrition is the provision of nutrition through the IV, right, intravenously. So parental nutrition is called multiple things. In the hospital, I've heard it called just PN for parental nutrition, TPN or total parental nutrition, PPN, peripheral parental nutrition, CVN, Central Venous Nutrition. Hyper-Al is like the old school that a lot of people still use. So it's called a lot of things, but basically when you describe it to patients, the easiest way to describe it is IV nutrition, so they understand that it's coming from an IV into their veins. Okay? So when do we use parenteral nutrition? This is a brief review from last time. So remember, if the gut works, we really want to use it, so that's when we would use tube feeds and parenteral nutrition. If the gut is not working for any reason, or there's some other indication that tube feeds is not appropriate for a patient, that's when we would use parenteral nutrition or IV nutrition. So any GI incompetencies, short bowel syndrome, if you have severe acute pancreatitis, if you have severe inflammatory bowel disease, so say all of your screens just blanked there for a second. So severe, not just if you have the diagnosis. Oh, come on, don't do this to me. There we go. Well, at least we have this one. Okay. If your bowel has lack of blood flow, if it's not working for any reason, major GI surgery, okay? Also, if you're a pleural enteral candidate, so remember MSOF stands for multi-system organ failure. Okay, if you have any major trauma, any small bowel surgery, immediately after surgery, usually you get bowel rest, and so that's when you would be given IV nutrition if that is prolonged. So when you wouldn't use TPN or IV nutrition, if your gut works. Sometimes this is very difficult to get the doctors to understand that. Also, TPN is a long-term issue, a long-term use, okay? We don't do TPN light. We should not be doing TPN light, okay? It's very expensive, and I put it that way because I love my oncology team, but there will be days where they're like, we're just gonna run TPN tonight to get him a little bit before he goes home tomorrow. And I'm like, not appropriate for many reasons. Okay. Also, patients that are very volume sensitive, because you are providing a large volume of fluid, because that's what the TPN is in. And then for people that have history of recreational IV drug use, it's not so much that they're going to abuse TPN, because it doesn't work that way, but a lot of times their access is not great. And so they might not be a good candidate, and it might actually cause problems if they do have poor access. All right, so again, enteral nutrition is more physiological. When we provide IV nutrition, we are not utilizing the gut at all. So even though patients may say they feel full, it has nothing to do with satiety hormones, because you're not using the gut at all. And it's very sometimes difficult to tell people that and get them to understand that. Okay, your enteral nutrition is going to maintain your gut integrity. So if you have somebody who's on IV nutrition for a long time, getting them to eat again is it's a slow process, because their gut sometimes is not maintained. Okay, when you initiate enteral nutrition, you have much more better outcomes in terms of length of stay, in terms of decreases risk for infections and so on, and costs a heck of a lot less to be tube fed than IV nutrition fed. And then you do have more of a risk for long-term micronutrient deficiencies, and you also get your liver starts to wear out after having IV nutrition for such a long time. All right, so let's talk about access, so I can tell you about Chester a bit more. So we have two types of access to get IV nutrition. We have central access, and we have peripheral access. We're going to talk about what that means. So central access is where the TPN or the CPN comes from. It's central parenteral nutrition, and that's when your catheter tip is inserted into the large high blood flow veins. So typically the superior and inferior vena cava, or the jugular. So we have a couple different sites that you can get central lines to be able to get your TPN in. So I have that up here, and then I have different examples of what lines look like in terms of when they're inserted in, and kind of which one TPN goes in and which one that medications would go in. So we'll go through these in a second. Okay. Peripheral access is what PPN refers to, or peripheral parenteral nutrition, and that's when your catheter tip is put into the small vein, and it's typically in your arm. So if someone's getting just an IV in their arm and they need like parenteral nutrition, but only for like maybe a week, and they don't need a big, large vein parenteral nutrition, it just goes into like a regular IV. Okay, so the big issue is that your size of how much nutrition you can get into those different spaces is quite a big difference. So if you have central line access, you can get quite a bit more nutrition, and most often than not meet nutrition needs for your patients on IV nutrition. For those that get peripheral only, more often than not, you're actually coming up a little bit short because you just can't get enough in there because of the milliosmolar max. Okay, so yeah, let's see. Here is what, again, central access looks like. So basically, this is your bag of IV nutrition, and it's going to be going through, it's going to be hooked up into a filter to go through a catheter to get into your central line access. So if you had central line access, you have basically a line that's placed in here. So this is what this would look like from the outside if you had an implantable port. So you just have the line that comes out, or external access, the line that comes out of the chest. If you had an implantable port, maybe you can't see this that well, but if you feel around here, there's like this little piece right here. So you don't have anything on the outside of your skin. It's because it's implanted underneath. This is why it's chest out. And so patients that have these types of ports, they can go home, they can swim, they can take a shower, no problem, but they have to be accessed anytime they need it. So for TPN use, this is not a long-term use. People can't go home and get TPN if they have this access because they would have to access the line themselves, and nurses do this, not us, okay? They have to come into clinic and get access. If patients have this type of line where it's external, they can't necessarily go swimming. They have to be really careful when they clean it. But they can get home TPN because they can just hook the bag up themselves, and that's how it is, how they're taught to do. So there are multiple different types of lines. Just to give you an example of like how you hang blood. Got a few of them back here. And you can hook up to the different tips here. So these are examples of different types of lines. Typically, it's great to have TPN when you have a patient that has what we call 2 lumens. One you can run the TPN through, and one you can run fluids or whatever else through, because TPN interacts with a lot of medications. So again, you have to think, if you're running TPN, if you have patients that get a lot of medications, you have to time them differently if they only have one line or one access to run them through. Okay? So this would be an example of a single access line, only one port. So if you had somebody who was getting TPN, they would only be able to run TPN, then they'd have to wait, then they can run their medications. Whereas a lot of times you can run 2 at the same time. All right, we're going to very quickly go through the composition. So there are 2 types of TPN that you have. Yeah, we have 2 minutes left. It's cool. We have 3-in-1 mixtures, which means literally you have fat, protein, and carbohydrate all mixed in one, or you have something called a 1-to-1 with a lipid piggyback, meaning you have carbohydrate and protein mixed together, and then you have an extra bag of lipid. Okay, so we have our amino acids as literally free amino acids. Okay, so TPN doesn't smell good. Gross. And then dextrose is the form of carbohydrate, okay? And that comes up when we talk about calculating our nutrient needs, because dextrose only gives you 3.4 calories per kilo or per gram versus regular carbohydrates that give us 4. And then lipids, okay? So you have to, when you're calculating out how much of each of these, you do it as a total volume percentage. The 1-to-1 with lipid piggyback is you have the amino acids and the dextrose in one bag, and then you have the lipids hanging separately. Yeah, exactly. So that's how it's provided. Okay. We will go through the rest of this next time because it's going to be too much to start. But we'll start with dextrose as our first macronutrient. If you guys want to take a look at Chester